So here we are with the last lecture for Chapter 20 on the urinary system about the elimination of urine from the body and the structures that are involved with elimination. Just as a warning, I am sitting in, of all places, a small office in a U-Haul return center right next to a highway. So if you hear voices in the background or if you hear cars rushing past on the highway, this is a makeshift recording studio that I'm sitting in right now, thanks to some really lovely ladies. So here we go. Urine collects then in the renal pelvis. The final product that is released from the distal convoluted tubules and into the collecting ducts, flows from down the collecting ducts through them into the renal pelvis, collecting in the minor calyces and then the major calyces, and then finally into the pelvis. And it is shunted from the pelvis into the ureters. The ureters are the tubes that connect the kidneys to the urinary bladder. The ureters are built of 3 layers, and the thickest of the layers is smooth muscle that is capable of contracting to help push the urine from the kidney into the urinary bladder. So the 3 layers, and we're working from the inside out. The innermost layer is the mucus coat. It is a transitional epithelium so that it can stretch as the ureters are filled with the passing urine. And it is continuous with the lining of the renal tubules. So all the way up the pelvis, this mucus coat extends up the pelvis and into the collecting ducts, all the way into the distal convoluted tubule and beyond. So it's one smooth, continuous lining to the interior of the tubules of the kidney. The next, the middle layer is built of smooth muscle, the muscular coat it's called, and there is both circular muscle and longitudinal muscle, so it can do the same kind of peristalsis that we associate with the digestive system and with the reproductive system. So we'll see peristaltic movements there, thanks to both circular and longitudinal muscle. And then finally, the outermost layer is a connective tissue. It is the, there we are, connective tissue that supports and holds and anchors the ureters in place. So for urine elimination to occur, waves of peristaltic contractions beginning up at up near the renal pelvis, so right there at the hilum of the kidney. That's where the peristaltic contractions begin, and they sweep along the ureter, forcing urine into the urinary bladder. Inside the bladder, there's a flap-like fold of the mucous membranes there that covers the opening of the ureter into the bladder. And so as the urinary bladder fills, that flap of mucous membrane seals against the opening into the ureter so that we prevent any of the urine that collects in the urinary bladder from backing up into the ureter. So this is a small bit of protection to help prevent bladder infection, or one of the outcomes of this is that it can help prevent bladder infections from backing up the ureter into the kidney. Now, that doesn't mean it prevents it 100% of the time, but that is one aid to that prevention. And occasionally, deposits that can form in the kidney, in the ureters, or in the urinary bladder. These, if they form in the kidneys, they're referred to as kidney stones or calculi. Calculus would be the singular. So if you have one kidney stone, you have a calculus, just like the mathematics. It's spelled exactly the same way. But if there are multiple of them, then they are calculi. The calculi are crystals of uric acid or calcium and magnesium salt deposits. So similar kind of materials. Well, yeah. So they're just, if overconsumption of calcium can lead to these crystallizations, overproduction of uric acid, magnesium, all those materials can crystallize, and then a calculus can grow larger and larger. And if, depending on where it forms, it can lodge in one of the small ducts or tubes. And so if it forms in the kidneys, it's very easy for even a small stone to cause a lot of pain. And sometimes they can be passed, and they pass into the renal pelvis, and then they get into a smaller space again, like an ureter, where they can become really painful again. And they will obstruct the flow, or they may obstruct or completely block the flow of urine. And if that happens, then the back pressure as urine is produced, back pressure up a collecting duct and up into the associated nephrons, can actually even prevent glomerular filtration. So you can get great enough pressure in the glomerular capsule that there's just not enough pressure to produce new filtrate. And so all of this is very painful. And so bladder infections, kidney infections, all of them can result as a response to these calculi forming and passing or moving around within the urinary system. Anybody who has had a kidney stone can tell you that they are miserable. And if you remember the whole story about referred pain, the pain from them is not just localized at the kidney, but can kind of spread down the thighs, the outer thighs especially, and kind of around a girdle, in a girdle around the waist as well. Okay, so continuing on now, the next structure in the flow of urine is the urinary bladder. And there are 4 coats to the urinary bladder. And again, starting from the interior, there is the mucous membranes of the mucus coats, and it is continuous with the ureters. It's also built of transitional epithelium. Remember, transitional epithelium is the epithelial type that appears to be cuboidal when the structure is relaxed, but as it stretches, it becomes more and more squamous, and so those cell layers begin to take on the appearance of squamous epithelium, although they are cuboidal when not distended. Deep to the or superficial to the mucus coat is the submucous coat. This is a connective tissue layer that has lots of elastic fibers, again allowing the distension that we associate with a full bladder to occur. Then external to the submucous coat is the muscular coat. It's also referred to as the detrusor muscle, so that's the name of the muscle that forms the bulk of the urinary bladder wall. And it is built of bundles of smooth muscle that run in all directions. So think about, what I like to think of as a way to think of it is it's a strengthening layer that is very strong, but also can produce a powerful contraction. And it's a little bit like particle board, might be a way to think of it, or if you know a little bit about construction, OSB, the oriented strand board, chip board, where you've got all sorts of small bits of wood that are just pressed together, and they lay out in no set organized pattern. The fibers run in every different direction, and it creates a It creates a strong muscle that when they contract causes a squeeze in all directions. You get force produced that is uniform across the urinary bladder. And at the distal end of the urinary bladder, closest to the outflow, the smooth muscle layer forms the internal urethral sphincter. And you're going to see a lot of similar comparisons to the internal and external anal sphincter as associated with the internal and external urethral sphincter. And then finally, external to the muscular coat is a serous layer. It is the, dadgum, did I really write parietal peritoneum? I did. I don't know what got into my head. It is not the parietal peritoneum. It is the, gee whiz, it is the visceral peritoneum. Again, I don't have the ability right now to write over the slide, but take a look at that and think it through with me, and you will recognize that, yes, there is a mistake. It's the visceral peritoneum, and it covers the surface of the urinary bladder and is responsible for secreting the peritoneal fluid that helps to lubricate the movements and all the movements associated with the organs of the abdominopelvic cavity. So as the urinary bladder fills, it stretches, and as though there are stretch receptors that notice that stretching and pressure that is building inside of the urinary bladder, and in response to that, it will produce a powerful involuntary contraction that forces urine from the urinary bladder. And we'll talk a little bit about how you can encourage that involuntary contraction to occur, but just like we talked about again with the digestive system, it is only involuntary contractions that move urine from the bladder and external to the body. Okay, so we will continue on from the urinary bladder. And that should not say, wow, that should not say urinary bladder at the top. It should say urethra. So we're talking now about the urethra. It's the muscular tube that leads from the urinary bladder to the exterior of the body. In women, it's relatively short, somewhere, a little less than an inch or so. And in men, it's much longer because it has to go up and over the bladder, and then the urinary bladder, and then down through the penis. So it's got a longer trip to make in men than it does in women. As the urethra passes through the floor of the pelvic cavity, there is a skeletal muscle that's external to the urethral sphincter, or that is distal. There we are. It's distal to the internal urethral sphincter. And it is a circular band of skeletal muscle that surrounds the urethra, and this is where we get voluntary or conscious control over when to urinate. And this is the muscle that we train when we're potty training a child, and that we can clamp down on, and we can even do some assistive muscles nearby. So if you're doing the Kegel maneuver, then that will help the external urethral sphincter to constrict, closing off the lumen of the urethra. So in females, the urethral orifice is located between the clitoris and the vagina, so it's in that same line. It is slightly posterior to the clitoris and slightly anterior to the vaginal opening. In males, because the urethra is long, there are 3 sections associated with it. There's the prostatic urethra. This is the portion of the urethra that passes through the prostate gland. And it also helps us to understand a little better why men who have had prostate surgery may lose continence, because there is damage to the nerves there. There can occur damage to the nerves that are associated with the prostate as well that will cause incontinence, the loss of control, because we lose some of that skeletal muscle control there at the external urethral sphincter. There is the membranous urethra. This is the portion that passes through the body wall. And then finally there's the penile urethra. This is the portion of the urethra that passes through the corpus spongiosum of the penis. And we haven't looked closely at the structures yet of the reproductive system, but those are the erectile tissues that cause, or that result, as they become engorged with blood, result in a male erection. So prostatic urethra, membranous urethra, and the penile urethra, or penile urethra. Okay, so we're closing in now on the very last bits. Micturition is the official term for the processes of urination. So as the urinary bladder fills and stretches, we see reflexive contraction of the smooth muscle of the urinary bladder. And as the urinary bladder contracts, it's going to then put pressure on the urine inside the urinary bladder and will lead then to elimination or discharge of urine through the internal and external urethral sphincters and then out through the orifice of the urethra, the opening. Conscious control can kind of get in there and interrupt or disturb the ability of the unconscious, of autonomic stimulation of the urinary bladder. So we can partially inhibit that reflex. But if we try to hold our pee, to try to prevent prevent contraction of the urinary bladder. If we try to do that for too long of a time, and the urinary bladder continues to fill and become stretched, then eventually that partial inhibition will go away, and we will lose control of the urinary bladder, and we'll pee our pants, essentially. So with conscious relaxation of the external urethral sphincter, then involuntary relaxation of the internal urethral sphincter will occur as pressure is provided against that internal urethral sphincter, and urination or micturition will occur. So there you have it. All that was fit to print about the urinary system. Again, as always, if you have questions about this this lecture, please make contact with me via email at bowlingcd. I'm sorry, that's the wrong one. Chuck Bowling at all one word at mcdowelltech.edu. Okay? Study well. Contact me if you need me. Take care. Bye.